Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I want to welcome you to the Journal Club for June. Really very, very excited about this Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recordings will be made publicly available. The participants with the cameras turned on will appear in the video recording. And we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulty or questions, please send a message or in the chat, and our technical team will hopefully be able to assist you with that. Excellent. Also, we do have time for questions and answer, and definitely encourage everyone to submit your questions via the chat function. So with that, then I would like to get on to the formal introduction. This month's lead article is Radical Vaginal Tricholectomy, Long-Term Oncologic Outcomes and Fertility Outcomes in Patients with Early Cervical Cancer by my dear friend and colleague, along with a number of other authors, Christhart Kohler. I'm really very, very pleased to welcome him to join our journal club. Obviously, I also want to thank him and the co-authors for submitting this article to the International Journal. So we're really very excited to hear about it. I invite everyone who has not read the article to definitely read it. And he's going to give us a brief presentation, but after that, we're definitely get to some questions. And again, we encourage questions from everyone as well. So thank you so much for joining. And Christhart, welcome to the Journal Club. Very excited to hear about this article and then move on with a discussion.
Pedro, thank you so much. First, I want to thank you and the entire team of the journal for selecting this paper as a lead article. It's the greatest honor for me and our team. And as already Achim Schneider pointed out in our last video discussion, not only that you have selected this manuscript for being highlighted by the leading topic this month, it was also a fantastic cooperation from the reviewers and you as the editor, as well as the editors and you as the editor-in-chief, to improve our manuscript and make it worth reading also hopefully for others. And I'm very happy that we can share now our experience on radical vaginal tricholectomy with you and all the readers and interesting colleagues in this field. Again, we have started very soon to apply this technique at this time, and at the university in Jena. This was the privilege and the work of Achim Schneider, who cannot attend this journal club today, unfortunately due to personal reasons. And that's why we were able to have a long-term oncologic and fertility outcome collection on patients who underwent radical vaginal trachelectomy. And I want to try to share you in a short summary our main result. All the previous case series had only limited numbers and a shorter follow-up time. And that we are very happy that we could collect data, demographic, histological, fertility, and follow-up data of all consecutive patients who underwent radical vaginal trachelectomy by our oncologic team over a 25-year period, starting in March 1995 up to August 2021. Altogether, we have performed 471 patients who collected 47,100 patients who underwent this procedure. 83% were nulliparous at the time of surgery, and FIGO distribution was stage 1A1 with lymph vascular space involvement in 9%, 1A1 multifocal disease in 2%, 1A2 in 20%, and the majority were stages 1B1 in 68%. Again, this was in accordance to the international accepted indications at this time. We are totally aware that during the last year there was a shift in the tendency for tailored radicality, but again at this time when we started, these had been accepted indications for this procedure. Due to the fact that we had very early started with the procedure, we can now present probably the longest follow-up of these procedures with a median of 13 years. Within this time, the tumor recurred in 16 patients. It means 3.4%, and 10 patients died of the progressive disease. Fortunately, we could show that patients who try to get pregnant after the procedure have a high success rate with a pregnancy rate of more than 70%. Unfortunately, and this has to be discussed probably also within this journal club, the preterm delivery is 46%, but we could consecutively reach a better obstetrical outcome with higher birth weights and the tendency to less earlier preterm deliveries in the last procedures. In conclusion, we present the long-term oncologic data in this manuscript of radical vaginal trachelectomy, and these data really can, for other techniques, serve as a benchmark for other fertility preserving strategies. And also we strongly recommend to extend the surveillance of these patients up to 10 years, because there was nearly 50% of recurrences recurred after 50 years, and this was also surprisingly for us to consider thus. Again, thank you so much for giving us the opportunity to present this data within this virtual journal club, and now I'm open for any discussion regarding the details of the manuscript and the data. Thank you so much.
Great. Thank you so much, Christhart, for that wonderful overview. And of course, obviously, we will have a number of questions. And I wanted to start just actually asking you, you've been performing this procedure for so many years. What do you think are the greatest challenges in actually performing the procedure? And what do you need to have in terms of background training as a surgeon in order to perform this procedure?
A very good question, Pedro. And again, you can believe me, I probably did all the mistakes in the beginning that you could do. And it is indeed a very meticulous surgery. And I think the key, and I also passed this had to pass this learning curve, is that you are very familiar not only with the exact anatomy from abdominal route or laparoscopic route, but also from vaginal route, and where is the meeting point exactly in between. And this is one of the keys in my opinion, that you have to have also in good teaching and learning in vaginal surgery, as well as in abdominal or laparoscopic surgery. And this makes it easier to combine the advantages of both procedures, and then it's a little bit easier to take over this procedure and learn the procedure. For those of us who are specifically trained only in abdominal or robotic route, it might be a little bit more difficult to learn, no question. But for those of us who are also having extensive vaginal training, it's not so difficult to combine both techniques and bring the best of both techniques together.
Great. Thank you so much for that, Christhart. And we'll start some of the questions from our fellows. First one is Natalia Palas, who will ask her first question.
Thank you, Pedro. First of all, dear Professor Kohler, I'm very pleased to be able to take part in this journal club. We send you the best regards from Linz. And my question is, you mentioned in this article that from systematic reviews, it seems that this vaginal route has the highest pregnancy rates compared to other trachelectomies. But why? How would you explain this?
Very good question. Thank you at first. Best wishes to Austria and to my friends in Linz. I think it is not so easy to answer because we are totally happy that we have such a high pregnancy rate. But if you want to say again, this is the one factor that makes it better than the other ones. It's impossible to say this. Again, I'm coming back to Pedro's first question. I think it's a combination of different factors. It's at first a very meticulous preparation. You do from laparoscopy to prepare the vaginal route, and then from the vaginal route you can take the best because you have everything under direct palpation and control. And this is sometimes for me better than to have it with even the robot or even from abdominal. Moreover, we probably have less adhesions. We have never checked it because we did not systematically do a second look laparoscopy. And but one of the factors also could be that we consequently preserve the uterine arteries on both sides. We never cut these arteries. And this is a little bit different to other techniques, especially to the abdominal route, where they routinely will be cut. And more and more we took more care, but this is probably another point of discussion later, for the maternal protection if the patients got pregnant after this procedure. And this is, in my opinion, the second important thing besides the surgery, the consequent good and improvement of maternal care if a patient is getting pregnant. And these combination might be the resulting in such a good pregnancy rate and in the last years better and later time of delivery to postpone the pregnancy as long as we can. But again, it's not one simple thing. It's probably the combination of all.
Great. Thank you so much, Christhart. Christhart, we have a question from the audience where they're asking, are all of these cases a two-stage procedure? In other words, are these all post-conization with all negative margin cases?
No, definitely not, Pedro. This is, okay, again, I think this is a very controversial issue that we have to discuss, especially now following the SHAPE trials and other trials. But in the past, this was not a point of discussion. The problem is if the patient comes to you, to the department, asking for fertility preserving, anything has done already, either one cone, a second cone, or only a biopsy. So we do not have a good influence how the previous diagnosis of these cancers had been before. Thus, we have to face and status, and then we have to handle this. And either you can decide, okay, summarizing all the results from histology and imaging, she is probably a candidate for this procedure or for a less radical procedure, or she's not. And I think, Pedro, maybe the others, I saw also Renee in the distribution here on the screen. I mean, will be the most difficult discussion regarding any fertility sparing technique in the future, summarizing the data of the previous therapy has already been done, and then to select, okay, which fertility sparing treatment is probably the best, because sometimes we will be tick too much, and sometimes probably also underestimated of the risk. And this is, in my opinion, the most difficult thing at the moment. And considering that even the 20 millimeter margin that was given us from the beginning was never statistically proven. It was in cutoff value that was implemented after having the first results. But no trial does ever exist who has checked 20 millimeters. So what are you doing in a patient with a 21 millimeter cancer in a code? Or these are the questions we face daily. And then it's difficult to say, yeah, we have to exclude you. Was 1 millimeter too much? Or it's already okay because the other histologic features are rather a better one. I think it's a daily open discussion, and I'm sometimes feel that I'm not able to say yes or not because all the information that we got in before are sometimes not sufficient enough, in my opinion. I don't know how you handle this, but I think this is a key question.
Yes, and we'll actually, I do want to come back to this point, and particularly also as it pertains to the criteria moving forward, given the results of the SHAPE, the CONSERVE, and GOG 278. So we'll be coming back to that point. We'll turn now over to one of our other fellows, Susan Dababu, and she's going to ask her question.
Hi, everyone, and thank you for the great presentation first, and congratulations. I would like to ask you, what is the pattern of recurrency after vaginal radical trachelectomy?
Oh, thank you so much for this good question. Again, we are totally unhappy about all the recurrences, and we were not able to treat all the recurrences by ourselves because they are distributed all over the country. Again, in the 10 patients who died out of the 16 recurrences, there were 5 distant metastases to consider. In 4, there was a predominantly pelvic recurrence, and in 1, we could not specify it from the letters we got back, and we got not more detailed information. Of course, all the 6 patients who are still alive had only a pelvic recurrence and were treated accordingly, and they are now alive without disease. But again, it's a combination of all the things. Was for us also surprisingly that we, in analyzing these 16 patients who unfortunately recurred after the procedure, there was no uniform pattern to say she is at, this is a patient, she is in higher risk. There were also patients who we would consider as very low risk, stage 1A1 without lymphovascular space involvement, grading 1, and no specific risk factors, no residual tumor, and this patient recurred. Normally, we wouldn't expect this. Whereas other patients where we had really a difficult feeling to perform the surgery, a 19 millimeter squamous carcinoma with lymphovascular space involvement, and also with perineural sheet involvement, which is very unusual in these small tumors, who insisted to have this surgery. She is free of disease for more than 8 years. So it's so difficult to say, okay, this is a uniform pattern. She probably has a higher risk and she doesn't have one. And that's why, again, it's difficult to decide for a patient, rather recommend to do fertility sparing or not recommend according to the histologic features we do have now at the moment.
And Christhart, as a follow-up to that, and since we're talking about recurrences, and I think one of the things that took a lot of people by surprise on the results of the study is that there were some recurrences that were really very distant from the time of the original surgery. Why do you think that is? And then also, should we change our pattern of surveillance of patients that undergo these fertility sparing procedures? Because we often tend to think, well, the recurrences are going to happen with the first 2 years, the most of them, and then after that is usually a few scattered additional recurrences, but definitely not after 5 years.
Very good question, Pedro. I do not have a good answer for this because, again, these late recurrences really surprised us dramatically. And so we had the same feeling as you mentioned it. Should we change our practice for follow-up in these patients? What is the best candidate for less or more extensive maintenance in this patient? And we also do not have a good answer for this. David Cipolla recommend to do regular HPV testing as well as a pap smear. Okay, this is no problem at all. But again, how do you handle the results? Sometimes you get a result, the patient again HPV positive, but the pap smear is okay. You don't find anything. Then you start with any imaging. The imaging is unsuspicious. So the patient is afraid of getting a recurrence, this young patient, okay, then you go to histology. Then we started to include tumor markers. Tumor markers rise, went down. It was like a wave, and with all the problems for the patient, she was totally frustrated, insisted for hysterectomy, and then we performed in DNC of the short cervix. Nothing, really no sign for nothing and no imaging. And again, this is these late recurrences also bring us to the question: should we do more routinely imaging in this patient? But this is not reimbursed in the medical system. Again, a lot of questions. We don't have the best answer at the moment. We still recommend to do in a regular sonography, pap smear, and HPV testing as a basic. And anything, if there's any suspicious and any symptoms of the patient, then extend it to the maximum. But I don't know, Pedro.
Yeah. So another question from the audience as it pertains to the preoperative selection. The question is pertaining to any tools or any tips you have with regards to potentially being able to detect parametrial involvement prior to surgery. Also, any level of stromal invasion that would exclude a patient from having this procedure.
I'm coming back, Pedro, same question. We have to discuss with the patient the therapy that had already done before she is admitted to the hospital. And sometimes it's very nice because they had only a biopsy, then you can make a very good imaging. You can decide, should we perform a cone or not, if it's totally unclear also. Then you have all opportunities. The nightmare is if already 1 or 2 cones had been done with unclear findings, then you have to discuss with pathologists you don't know, to ask them, could you please review again your report and give me a more detailed information? And sometimes you meet some very kind pathologists who they tell you, yes, thank you for this kind hint. Others tell you, yeah, it is as it is. And then you are in trouble because you have to make a decision: is she already still a candidate for this procedure or not? And I think this is the most difficult part at the moment. The surgery is relatively standardized for at the moment for our team, and there we also made some modifications as previously also in your journal published with the urethral dissection, and so also to make it a little bit easier. But the key question is how to select the patient. I completely agree with you, and I don't have the best answer at the moment.
Okay, we'll go to Matteo Pavone in Italy.
So thank you, Professor Kohler, for such great and impactful research. My question is, in your study, the first half of the cases had more preterm birth. What is the secret to lower the preterm rate?
Thank you so much. It's also a very good question. I think in the beginning, when we started with the procedure, we were happy that we could finish the surgical procedure, and we took more care for surgical aspects. And very soon it came apparent that the second part of the surgery is the antenatal care. And at the beginning, we didn't really took care. We sent them to the obstetric department and said, okay, we did a shortening and you have to deliver by cesarean section, and that's all. But this is I think this was a totally mistake from us, because it's very difficult to give this patient good advices for the time of the pregnancy, because the pregnancy and not the delivery is a key for the best obstetrical outcome. And I think the main question is to avoid any infection, vaginal infection, because this is due to the shortening of the cervical length to the lower isthmic competence. This is the problem for any preterm delivery, is the infection, and to really strong advise these patients to do anything that can avoid infection. That means consequent abstain from sexual contact, consequent treatment and control of vaginal infection by measurement of pH value, and if there's any change, consequent treatment, and advice of progesterone at the beginning from the when pregnancy was detected. Other groups recommend application of metronidazole from the 15th or 16th week until the 28th or 20 weeks of gestation to avoid any infection. And this is in combination with a reduction of physical activity. Again, it's a mixture of different tools. We also don't know which is the best and most important, but this combination and really strong advice to this woman gave us the opportunity to improve the antenatal care in higher weeks of gestation, and thus to increase the birth weight of the children. But again, I don't know which is the best one of all these combinations.
Hey, Chris, a question from the audience. This is from Nico Bizzari Gemelli in Rome. And he's asking, in your practice, how long after the procedure do you give the patient the green light to conceive?
I think the green light to conceive is if the wound healing is finished. And this is for me 2 or 3 months following the procedure. I think there's no specific reason to say wait for a longer time. I think this argument came back from what you told before, Pedro, to say, okay, we were afraid about recurrences within the first and second year. Let's wait 2 years for if the recurrence occur, and after this the risk is relatively low, and then to try to conceive. But again, this is not confirmed by our data. The recurrence rate is low at all. So why waiting for a longer time? And you have to consider these patients are sometimes close to the 40s. So the chance to get pregnant is lower by biological age. So why are we waiting for 2 additional years?
Excellent. Very well. It's a follow-up question to that. Has the interval between surgery and pregnancy been analyzed for an association for recurrence?
No, unfortunately not.
Okay.
It's a good hint. So sorry, but we didn't do this. It's a very good hint. Thank you.
Excellent. Very well. So we'll go to Spain now. Rosa Montero. And I don't see Rosa connected, so we'll go to Ana Luzarraga.
Congratulations, Dr. Kohler, for this amazing article and discussion. So my question is there an adequate time interval for a prior conization and the radical vaginal trachelectomy? Thank you.
Yeah, thank you for this important question. Indeed, we still wait approximately at least 4 to 5 weeks, because this is the bad experience having had in the beginning. If you start 2 or 3 weeks following conization, we have a very soft and fragile tissue from the conization, which is in healing. And that's why, again, this was sometimes technically more demanding. That's why we decided again, wait until the conization wound is completely healed, and this is about at least 4, maybe 5 to 6 weeks. And this is also very well fit this to our schedule of the surgery, because our surgery plan is mostly 4 to 5 weeks in advance, so it fits perfectly to this time. But again, it's only empirical. There's no science for this interval.
Excellent. Then I think Rosa is connected back again. So
yeah. Sorry,
right.
I lost the connection. Yeah, sorry. Thank
No
you so
problem.
much. So I would like to ask you, is systemic vaginal smear cytology an effective way of follow-up? How do you conduct follow-up for your patient? Thank you.
Thank you for this nice question. I think we already discussed a few aspects of this. We do routinely, and this is in accordance with the German guidelines for any cancer. We do pap smear and HPV testing each 3 months. But again, the problem is how to handle any abnormalities, and you very often find ups and downs in both in the HPV positivity, negativity, and also in the pap smear, and this is sometimes difficult to handle for this patient. As soon as we get such a result, again, in our policy, we extend the follow-up to perform an MRI, and if there's any unclear finding, then we very short office curettage of the remaining cervix in order to exclude the recurrence. Very short procedure, sometimes demanding to find the entrance in the very short cervix. But again, it's also for the patient very important to have the knowledge that they don't have a recurrence, and they can continue with their plan to get pregnant in the next or actually in the close future. But again, the pap smear can be difficult. I completely agree with you.
And Chris, there's a follow-up to that, and you did mention MRI, but one of the questions from the audience, is Sarita Sharma, is do you routinely get MRIs on every visit, or this is just whenever you have a suspicion that something is abnormal?
We do routinely an ultrasound, and if there's any unclear finding, we immediately send them to the MRI. But we don't do it routinely an MRI in all patients.
Okay, excellent. Very well. There's another question from the audience. How do you plan or do the lateral margin of recession during the procedure to be microscopically negative? Does ureteric canal dissection also, is it done by vaginal approach?
Sorry, can you repeat, please, Peter?
Yes, I'm trying to understand the question a little bit better. Lateral margin of resection during the procedure. How do you assure that the lateral margin is negative on the during the procedure?
In my opinion, it's not really possible to get this information. I know that a few centers perform a frozen section on the margins, but I'm not convinced of this, because we did the same, and we had 1 or 2 times a questionable result, because the pathologist told us it's for us impossible to give you a definitive answer. And I mean, for this patient, this is the most important question to continue or not continue with the procedure. Thus, we decided we perform a frozen section with all the, I don't want to open the box of the Pandora in this field from the central or the lymph nodes. And we send the lymph nodes, again, this is one of the, I think, accepted contraindications to have a lymph node metastasis. Thus, again, we consequently send all removed lymph nodes to the frozen section. And when we get the result of 3 nodes, then we can continue. Then we continue with radical trachelectomy. Fortunately, we did find in only 1 or 2 patients that we had very close margins to the remaining tumor, and thus we recommended the patient an additional therapy. But again, coming back to this problem, what is the adequate margin? So as you probably know, Patrice Matoué, I asked him, he was a fellow at this time of Daniel Dargent. I asked him once at an ESGO meeting for the cervical guidelines, how do you fix the 5 millimeters? What is the basic and data basic for the 5 millimeters? And the data basic for 5 millimeters is a morning coffee sitting by Daniel Dargent at his hospital. We don't have any evidence about 5 millimeters, nothing. Thus, again, the question is, the colleagues from the Gemelli Hospital, they recommended from, as I know in the paper, 3 millimeters coming from radical hysterectomy specimen. Again, it's totally questionable, and that's why it's so difficult. And we don't believe in a frozen. I don't believe. I must tell, I don't believe in a frozen section of the margins. Again, if we have negative lymph nodes, we continue to and finish the trachelectomy, and then we wait to definitive histology. Then it can occur that we have to discuss with the patient the questionable result and advise her any additional adjuvant therapy, as pointed out in the paper. Only a few patients had to undergo additional adjuvant treatment.
Great, thank you so much, Chris. Did you mean that what comes out of a morning coffee discussion is not evidence-based medicine?
Not really. I love the morning coffee discussion, but the evidence is more low.
Because you and I have had many discussions over morning coffee, and we thought that was evidence-based, right? So the next question is Osna from Israel.
Hi, thank you. I'm going to join in congratulating you for this manuscript, and thank you for that. I wanted to ask, you mentioned in your reported pregnancies in your manuscript that there were 4 pregnancies that were ongoing. Could you tell us what happened with those 4 pregnancies?
Oh, thank you for this. Is a very nice and warm question. Thank you so much. All these 4 women gave birth to a healthy baby, on term, and also in the 1 in the 20th, in the 33rd, and 1 in the 35th week of pregnancy. So we have 4 additional healthy babies. So we are very happy about this. Thank you so much.
So, Christhart, we have about 5 minutes, and love to hear Renee's input as well. And I want to thank all the fellows for their questions. But I wanted to ask you, obviously, there's a lot of young trainees or young faculty in the audience, and this is a question that came up during our podcast as well, with the results of the CONSERVE, basically saying conization is feasible, with the shape suggesting that simple hysterectomy is appropriate in select patients. And the recent presentation at the SGO on GOG 278 also supporting this principle. The question is, and I'll ask again, and we asked this in the podcast, is there any future that you see for radical vaginal trachelectomy? In other words, for many in the audience who might say, do I embark on learning this procedure, or do I just obviously read about it, but knowing that moving forward, this may not be a procedure that is done routinely? What are your thoughts?
Renee, are you also with us at the moment? Of course, I have read with pleasure your comment in the journal. And I'm very happy that you this time did not write that we were drunken to do the surgery compared to the command to the uterus 11 trial. So I'm very happy about this very more privileged comment this time. But anyway, I completely agree with you. I think the intention of the manuscript were for two reasons. Of course, demonstrate the excellent outcome, but again, also to raise the question: is this also in updated surgery up to now? And the answer is, Pedro, I really don't know it, because we lose more and more the in our country, hopefully not in others, we lose more and more the skills for vaginal oncologic surgery. It's dramatically, because very few people are interested in taking over these procedures, which is, in my opinion, a pity, because the results are really encouraging and excellent. That's a pity, in my opinion, but I know that the technique is demanding and difficult to learn, and it takes time to take it over, no doubt. But I think it's also difficult to learn other procedures in oncology, even open or robotic, to get a good level of experience. And I think it's also a little bit the question of, do I want to learn this procedure or not? The second problem is, again, I completely agree with you, is a question of indication. We go to less radical surgery, and this is totally in agreement, because the accepted indications in the past were too extensive and for too lower stages of diseases. The main problem, again, we raised the discussion several times within this meeting now, is who is really the patients that need a more radical procedure. The indication will be totally less numbers, but for these patients, we still need this technique. And then within the other techniques, to say, okay, these patients, by the way, have a higher risk than we do abdominal, besides the fact that the pregnancy rate is nearly half of the other one. It's a little bit unfair for these patients, and we would need a few people who really are still experienced in this technique to offer this for the smaller cohort of patients that really need a radical procedure. Again, these long and huge cohorts should really be a benchmark for all the upcoming new studies, to say, okay, same indications, clear indications, what is the outcome for this tailored surgery, and this again should always in comparison to this encouraging data. But again, I agree with you. Radical vaginal trachelectomy is a questionable technique because it's difficult to learn. We see less indications for doing this. And the only argument, or one argument is, and here I'm a little bit in a disagreement with Marie Plant from Canada. She proposes a simple trachelectomy, and the technique of simple and radical vaginal trachelectomy, it's a difference, no doubt, but the difference is not so big. And if you want to learn the simple vaginal trachelectomy, you also should be able to do the radical vaginal trachelectomy. It would be ideal to have a team or some colleagues that should be able to do both of them.
Very well. So now, Renee, obviously, Latin America, where cervical cancer is significantly much more prevalent disease than it is in the US and potentially in Europe. do you see a role for this procedure in terms of the routine teaching and training of our residents? Do you see a role or an indication for the majority of patients with early cervical cancer?
Thank you for your question, Pedro. First of all, I would like to congratulate my dear friend, Christhart, for being a leader of thinking and doing radical trachelectomies together with the French and Spain people. But in America, few people perform vaginal radical trachelectomy. Erasmo Bravo from Viña del Mar in Chile, Susana Pesini in Porto Alegre in Brazil, Yukio Sonoda in New York, and the Canadian ones. In the rest of Latin America, we perform open radical trachelectomies or laparoscopic or robotic radical trachelectomies because the technique is difficult to teach, it's difficult to learn, and it's a technique that eventually, at the end, will disappear. As disappear, the open cholecystectomy, and no one is missing it because cholecystectomy is a laparoscopic procedure, not an open one. The same story happened with the surgery of the breast cancer. First, Halston mastectomy, including the pectoral, then modified mastectomy, then quadrantectomy, and now lumpectomy or just tumorectomy. So the surgery tends to decrease in size. So we have to respect the criteria from conserve, from DOG 27A, and even for shape. And if the patient does not comply with those selection criteria, probably will be the ideal candidate for radical trachelectomy. If you want to perform it through vaginal way, it's okay, or laparoscopic or open, but to select the right patient is crucial. And most of them can spare a radical procedure if the criteria of the aforementioned studies are accomplished with the surgical specimen. Christhart, it's always great to see you, my dear.
Same to you for me too, Rene. But again, I think there's a totally agreement, Rene. In the root, this is very similar for me. Sorry, Pedro, for like the leg trial. The radical hysterectomy has to be performed in the same way, in the same extent, unregardless the approach you do, and under the same safety conditions and with the same oncologic outcome, unless the route of surgery you have chosen. Again, I've learned this technique, and I know also the advantages of the technique, but definitely also the disadvantages. And I only can tell it's a very nice technique, a very meticulous technique. But again, there are also other techniques that potentially offer the same result. This is no doubt about this. But one very similar thing, when we shouldn't forget this technique in totally. For example, when Achim Schneider started to reintroduce the combined radical vaginal hysterectomy in the 19th of the last century, they were looking for someone in Germany who was able to perform it, because the technique was lost, totally lost in Germany. So it was difficult to find 1 or 2 or 3 colleagues from Austria and Germany to help them to start with the procedure and then continue with the technique, and again with modifications and so on, to make it again, bring it again on a level that is similar to the open technique. And I think it would be it's one of our tools that we do have, our good tools, and we shouldn't lose it in total. I agree with you, Rene. For a lot of cases, there are other options and opportunities for doing this, but there are also a few cases left and a few indications left where we should perform it. The problem is, then we need a few centers in the world that should be able to do it.
Well, with that, I want to thank you. Obviously, Christhart, always great to see you. And again, I have a tremendous amount of respect for you and the legacy that you have left in the field of gynecologic oncology. certainly remember reading your manuscripts from very early on in my training, and always being very, very impressed. And I really appreciate you taking the time to discuss this manuscript with us. I want to thank all of the fellows for, number one, participating, number two, submitting their questions. And I do want to thank every single one of you who attended the Journal Club. We had over 54 participants to this Journal Club, so I'm really very, very happy with you attending this session. I want to remind everybody that recording of today's sessions will be available in the IJGC, IGCS, and ESGO websites. And do remember to join us at the July Journal Club to discuss the role of systematic lymphadenectomy at the time of interval debulking surgery for patients with advanced stage epithelial ovarian cancer who achieve complete gross resection. So thank you again so much to everyone. And Christhart, once again, thank you.
Again, Pedro, I have to thank all the participants for their very interesting questions, you for the opportunity to give us a chance to present here, and personally, my best regards to Claude.
All right. Take care. Thank you.
Bye-bye.